Calcium channel blockers work by blocking L-type calcium channels located in vascular smooth muscle and the myocardium. This action prevents calcium from entering cells, which leads to vasodilation and a reduction in cardiac contractility, ultimately lowering blood pressure. Calcium channel blockers are broadly classified into two main groups. The first group is the dihydropyridines, which act primarily on blood vessels. Common examples include amlodipine, nifedipine, and felodipine. The second group is the non-dihydropyridines, which have more pronounced effects on the heart, specifically on the sinoatrial and atrioventricular nodes, as well as on myocardial contractility. Key examples here are Verapamil and diltiazem. The clinical indications for these drugs extend beyond hypertension. They are also used for chronic stable angina and, in the case of Verapamil, for supraventricular tachycardia. Dihydropyridines can be helpful for conditions like Raynaud phenomenon due to their vasodilatory effects. The side effect profiles differ between the two classes. Dihydropyridines commonly cause flushing, headache, and peripheral edema, which happens because of fluid redistribution rather than fluid retention. They can also cause reflex tachycardia. Non-dihydropyridines, on the other hand, are more likely to cause bradycardia, heart block, and constipation, which is especially common with Verapamil, and they should be avoided in patients with heart failure with reduced ejection fraction. For dosing, a typical example is Amlodipine at 5 to 10 milligrams orally once daily. For Verapamil, the immediate release form is 80 to 120 milligrams 3 times daily, while extended release formulations range from 180 to 240 milligrams once daily. A critical caution is to avoid combining non-dihydropyridines with beta blockers due to the additive risk of heart block. Also, patients should be warned that grapefruit juice can significantly increase drug levels. Moving on to alpha blockers. These agents work by selectively blocking alpha-1 adrenergic receptors on vascular smooth muscle, leading to vasodilation and a reduction in peripheral vascular resistance. Common examples include Doxazosin, prazosin, and tachycardia. While they can be used for hypertension, they are often relegated to adjunctive therapy because of their side effect profile. However, they are highly effective for treating benign prostatic hyperplasia, or BPH, which is a common indication today. The most important side effect to remember is first-dose syncope, a dramatic drop in blood pressure after the initial dose. Other effects include orthostatic hypotension, dizziness, and peripheral edema. A typical dosing example for doxazosin is to start at 1 milligram orally at bedtime to minimize the risk of syncope, and then gradually titrate up to 4 to 8 milligrams once daily. The key caution here is simple. Always start with a low dose at bedtime and warn the patient about the possibility of dizziness when standing up. Finally, we have centrally acting agents. These drugs work in the brainstem, where they stimulate central alpha-2 adrenergic receptors. This action reduces sympathetic outflow from the central nervous system, which in turn decreases peripheral vascular resistance, slows the heart rate, and lowers blood pressure. The main examples are Clonidine, methyldopa, and guanfacine. In terms of indications, Clonidine is sometimes used as an adjunct in resistant hypertension. Methyldopa holds a special place as a preferred agent for treating hypertension in pregnancy due to its established safety record. Side effects are often what limit the use of these drugs. They include sedation, dry mouth, fatigue, and bradycardia. A dangerous feature is rebound hypertension, which occurs if Clonidine is stopped abruptly after chronic use, causing a rapid surge in blood pressure. For dosing, Clonidine is typically started at 0.1 milligrams orally twice daily, titrated up to 0.2 to 0.6 milligrams per day in divided doses. Methyldopa is given at 250 to 500 milligrams orally 2 to 3 times daily, with a maximum of 3 grams per day. The golden rule with centrally acting agents, especially Clonidine, is to never stop them suddenly. They must be tapered down gradually to avoid a rebound hypertensive crisis. Thank you for watching. Don't forget to like, share, and subscribe.